And now it's my great pleasure to invite Professor McMurray to enlighten us whether the use of sacubitril valsartan and SGLT2 inhibitors gives consistent benefits across all patients with heart failure with mildly reduced ejection fraction and preserved ejection. John, over to you.
Thank you, BJ. Are you able to see my slides okay?
Yes, John, we can.
Okay, thank you very much. So thank you for inviting me to join this meeting, and it's always great to hear Javed talking, especially when he's reporting such exciting new data as we saw for STEP-HFpEF. So I'm going to talk about ARNIs and SGLT2 inhibitors, and as you heard in the introduction, focus on this very important question about whether they are beneficial truly across the whole spectrum of ejection fraction. We know that they undoubtedly are extremely effective in people with an ejection fraction of 40% or less, patients with HFrEF. But what about patients with an ejection fraction above 40%? And in particular, what about people who have the syndrome of heart failure, but essentially a normal ejection fraction? Do these drugs really work in those patients? So that's what I'm going to try and address in the next 20 minutes or so. These are my disclosures. So I'm going to start with ARNIs, and of course, inevitably, I've got to go back to 2019 and mention the Paragon heart failure trial, which was the sister trial of Paradigm heart failure. This was a large trial in which we randomized patients to receive sacubitril valsartan or valsartan, so basically testing the effect of sacubitril, an neprilysin inhibitor. This was in around 4,800 patients with the clinical syndrome of heart failure, an ejection fraction of 45% or above, and other evidence of cardiac dysfunction. So structural heart disease, defined as left ventricular hypertrophy or left atrial enlargement, and a modest elevation of natriuretic peptides. Primary outcome was cardiovascular death and heart failure hospitalizations, but unusually for trials looking at the total events that occurred, not just the conventional time to first occurrence of either of these outcomes. We looked at all cardiovascular deaths and all heart failure hospitalizations. So this was the result of that analysis for the primary composite outcome. You can see that in the patients who got sacubitril as well as valsartan, the event rate was lower than in the patients who got only valsartan, but this 13% relative risk reduction was not statistically significant. The upper 95% confidence interval is 1.01. The p-value was approximately 0.06, so we did not achieve statistical significance. This was overall a neutral trial, but borderline. What was interesting, however, was the pre-specified subgroup analysis according to left ventricular ejection fraction. And we said when we designed the trial, when we wrote the analysis plan without knowledge of the results of the trial, that we would split patients into half. So we would look at the half who had an ejection fraction above the median value, which turned out to be 57%, and the half of patients who had an ejection fraction at or below that median value of 57%. And the reason this was interesting was that there was a significant interaction according to ejection fraction. So in other words, ejection fraction modified the effect of treatment. And the modification that we saw was that in patients with an ejection fraction at or below 57%, there seemed to be a benefit, where there was no obvious benefit in people with an ejection fraction above 57%. But that was a subgroup analysis in a trial that overall had a neutral effect. So there was and still is, some discussion about whether or not we accept this as a real finding. I'll come back to that in a moment. Perhaps a better way to look at this, instead of dividing an ejection fraction into two groups, is to look at it as a continuous variable. And with Paradigm and with Paragon, we've essentially got a large number of patients, in fact, about 14,000 patients across the whole spectrum of ejection fraction. And this is what that analysis looks like. So now you see cardiovascular death or heart failure hospitalization. This is back time to first event. The solid blue line on this figure shows you a continuous hazard ratio. The shaded blue area around that line are the 95% confidence intervals. Unity, so a hazard ratio of 1, indicating no difference between angiotensin receptor blocker therapy. This should actually say renin angiotensin system blocker therapy or sacubitril valsartan. A hazard ratio of 1, unity, means no difference. And here the hazard ratio was below 1, in other words, indicating benefit across the ejection fraction range up to an ejection fraction, as you can see, between 55 and 60%. Now, I'm going to show you some new data that perhaps add support to the view that those findings are valid findings, that there really is an interaction between ejection fraction and the effect of sacubitril valsartan. And that comes from this smaller trial published earlier this year called Paraglide Heart Failure. Paraglide Heart Failure was, as I said, a small study, relatively speaking, with around 460 patients. It was also a short-term trial, so the duration of follow-up was only 8 weeks. Patients again were randomized to sacubitril valsartan or valsartan, and because this was a relatively small trial, the primary endpoint was a biomarker endpoint. Clinical events were looked at, but the primary endpoint was reduction in NT-proBNP. And the patients enrolled in this trial had an ejection fraction above 40%, and they had recent deterioration in heart failure, recent worsening of their heart failure. In other words, they'd either been admitted to hospital or they were enrolled within 30 days of an episode of worsening heart failure that required treatment with intravenous diuretic, either in the outpatient or emergency department setting. Very, very importantly, in light of what I just showed you a few moments ago, there was a pre-specified subgroup analysis looking at whether or not patients with an ejection fraction of 60% or less had a different treatment effect than patients with an ejection fraction above 60%. In other words, could that apparent modification of the effect of sacubitril valsartan by ejection fraction be confirmed in this second separate trial with a biomarker endpoint? So here's the overall result of the Paraglide heart failure trial. You can see that there was a reduction in NT-proBNP. It was statistically significant. It was relatively modest, 15% reduction in NT-proBNP seen within a week of starting treatment. But what was very interesting was that pre-specified subgroup. So here you see the patients with an ejection fraction between 40 and 60%. The right-hand panel shows you the patients with an ejection fraction above 60%. You can see that clearly patients with an ejection fraction 60% or below had a larger reduction in NT-proBNP, and there simply was no reduction in NT-proBNP observed in patients with an ejection fraction above 60%, and there was a statistically significant interaction between ejection fraction category and the effect of sacubitril valsartan. So this lends support to the view that there really is a modification of the effect of sacubitril valsartan by left ventricular ejection fraction, and that patients with an ejection fraction in the 40s to 60% range do show some, at least biomarker evidence of efficacy from neprilysin inhibition. But what about clinical outcomes? Do we have any additional evidence? And here we do, because there was, again, a pre-specified participant level pooled analysis of the Paraglide and Paragon heart failure trials. So this is now looking at total heart failure events or cardiovascular deaths. So this is the primary outcome in the Paragon heart failure trial. There were two analyses, two populations examined. One was the patient Paragon heart failure who were Paraglide-like, and there were 622 patients like those enrolled in Paraglide included in Paragon heart failure. So we had 1,088 participants in the two trials with recent worsening heart failure. So this was the sort of primary population for this analysis, but all patients in both trials combined were also analyzed. And of course, we had a pre-specified subgroup analysis according to left ventricular ejection fraction, again, to test this hypothesis that ejection fraction modified the effect of sacubitril valsartan. So here in the primary population, the 1,088 patients with an ejection fraction above 40% who had recent worsening of heart failure, you can see that overall there was a significant reduction in total worsening heart failure events, cardiovascular deaths, 22% relative risk reduction, statistically significant. But again, I think very importantly, if you look here at the subgroup analysis by ejection fraction, you can see again the strong suggestion, although this was not statistically significant, of an interaction whereby individuals with an ejection fraction of 60% or less seem to get a greater benefit than patients who had an ejection fraction over 60%. And of course, in the larger population, so this is now all patients in Paragon and in Paraglide combined, again, overall, a statistically significant reduction in events, and again, an interaction, this time a statistically significant interaction between the effect of sacubitril valsartan and ejection fraction, with a greater relative risk reduction once more in patients with an ejection fraction of 60% or less, with no evidence of benefit in people with an ejection fraction above 60%. Now, very quickly, I just want to remind you again that there is other evidence to support this idea that ejection fraction does modify the benefit of treatment. And of course, we have other treatments that have been assessed across the range of ejection fraction. Maybe most obviously that is in patients with treated with candesartan in the CHARM program, but also with MRA therapy. So here's the CHARM program and iPreserve, another trial with a different angiotensin receptor blocker combined. So again, we've got around 12,000 patients here treated with an angiotensin receptor blocker or placebo across the spectrum of ejection fraction. Once again, the continuous hazard ratio, a borderline interaction, a statistically significant interaction, but again, very strong suggestion that once more you see the same sort of modification of the effect of therapy, whereby the effect of angiotensin receptor blocker treatment is clear in patients with an ejection fraction below normal, but in people with an ejection fraction certainly above 60%, there doesn't appear to be any benefit of treatment. And we can do the same analysis by looking at RALS, emphasis heart failure, and the patients from North and South America included in the TopCat trial. So again, looking at MRA treatment across the range of ejection fraction. And you can see once more the same pattern, this time with a very strong interaction between the effect of MRA therapy and ejection fraction, once again with attenuation of benefits of this particular neurohumoral therapy, once more in patients with an ejection fraction above 60%. So we have new evidence with sacubitril valsartan from the Paraglide trial. We've got supporting evidence with other neurohumoral therapies to suggest that that observation in Paragon heart failure is probably true, and that, at least for neurohumoral therapies, ejection fraction modifies the benefit of treatment. Well, what about SGLT2 inhibitors? That was the other treatment I was asked to talk about. And we realized that our European Society of Cardiology guidelines were already out of date almost the day that they were published, because just after we published the guidelines, Javid and colleagues published the Emperor Preserved trial with empagliflozin in patients with heart failure and an ejection fraction above 40%. And then last year, we published a very similar trial with dapagliflozin called DELIVER. And because of the importance of those two trials, the ESC, for the first time ever, has published a focused update of one of its guidelines. And about 3 weeks ago, we published a focused update of those 2021 heart failure guidelines during the ESC Congress in Amsterdam. So Emperor Preserved and DELIVER, two very large trials, around 6,000 patients each, including patients with mildly reduced and preserved ejection fraction. They both had a median follow-up of just over 2 years. They had slightly different primary endpoints. Emperor Preserved, it was time to first occurrence of cardiovascular death or heart failure hospitalization. In DELIVER, it was time to first occurrence of a worsening heart failure event or cardiovascular death, although most of these worsening heart failure events were heart failure hospitalization. So that we can look at these two treatments in the same way. I've shown them here, the two trials showing the effect of SGLT2 inhibitor therapy on the composite of cardiovascular death or heart failure hospitalization. In the two trials, you can see the hazard ratio is almost identical, the same very rapid onset of benefit, highly statistically significant, around 20% relative risk reduction. If you put these two trials together, there was a borderline reduction in cardiovascular death, a clear reduction in heart failure hospitalization, clear improvement in symptoms and quality of life, clear reduction in risk of worsening of symptoms and quality of life. And also in the two trials, evidence that SGLT2 inhibitors, as they do patients with diabetes and patients with chronic kidney disease, and in patients with HFrEF, they also reduce the risk of deterioration in kidney function over time. And indeed, we've got more evidence that these drugs work across the ejection fraction spectrum, from a further trial, the Soloist Worsening Heart Failure trial, smaller trial this time, trial including patients across the range of ejection fraction, patients with type 2 diabetes, so different than the other 4 trials, only patients with diabetes. These are patients with established heart failure admitted to hospital with worsening of their condition. Here's the primary endpoint. And in that trial, once again, very clear evidence of benefit. You almost don't need to do the statistical analysis to see that this benefit is clear. And in the pre-specified subgroup analysis of the soloist worsening heart failure trial, patients with an ejection fraction of 50% or above obtained the same benefit as patients with an ejection fraction less than 50%. No evidence of an interaction between ejection fraction category and the evidence of treatment. So that is the question: were we going to see the same picture with SGLT2 inhibitors that we've seen with our conventional therapies, all our neurohumorally acting treatments? And we've done this analysis. So in all of the patients enrolled in the DELIVER trial, 11,000 patients across the spectrum of ejection fraction, the picture is completely different. As you can see here, the hazard ratio is consistently below 1, no evidence of interaction between ejection fraction and the benefit of treatment. So, and the Emperor investigators have done a very similar analysis with similar findings. So what is clear is that SGLT2 inhibitors, unlike other therapies, do not show this evidence of attenuation of benefit of treatment in patients with a normal ejection fraction. You can see here that the hazard ratio is consistently below 1 and not attenuated in people with an ejection fraction above 55 or 60%. So this really is a breakthrough for patients with heart failure and preserved ejection fraction who did not previously have any evidence-based treatment. And as a result of that, the new 2023 ESC focused update on the heart failure guideline gives SGLT2 inhibitors the strongest possible recommendation, both in mildly reduced and in preserved ejection fraction. And this really is the important new recommendation, class 1, level A. You can't get better than that for dapagliflozin and empagliflozin. So really important for patients with heart failure and preserved ejection fraction. And in the ESC guidelines, here's the treatment algorithm. Now, it is interesting that sacubitril valsartan is only recommended in patients with mildly reduced ejection fraction. So that is in the range 41 to 49%. I showed you evidence, I believe, supports the use of SGLT2 inhibitors to a higher ejection fraction than that. So I think this could be an interesting point at which guidelines around the world might diverge. Already regulatory authorities around the world have diverged in terms of labeling for sacubitril valsartan. And if this recently published consensus document is anything to go by, then perhaps future American guidelines might also differ from the ESC guidelines. So this expert consensus suggests that SGLT2 inhibitors for HFpEF will probably get a class 1 recommendation. That is why this yellow diamond is surrounded by a green line. This was published before the ESC guidelines came out, but you can see down here that there are recommendations for use of sacubitril valsartan. It says here for women with all ejection fractions and for men with an ejection fraction up to 55 or 60%. So again, we can maybe discuss why men and women have been differentiated here, but this is clearly different than the ESC guideline that I've just shown you. My own perspective to finish with is summarized in this review that Akshay Desai and colleagues wrote. And here you can see that we suggested in our recommendations that we mustn't forget about the value of exercise, SGLT2 inhibitors across the whole range of ejection fraction, diuretics to treat congestion across the whole range of ejection fraction, of course, management of non-cardiac comorbidities, and one of those would be obesity across the whole range of ejection fraction. And here you see that we do suggest using ARNIs and MRAs, at least in some patients, up to an ejection fraction of 60%. So with that, I'd like to thank you very much indeed for listening. And I hope you'll come to our Congress next year, where hopefully we'll see more interesting trials like STEP-HFpEF. Thank you very much.
Thanks, John, for a great presentation as usual. As you have told us, SGLT2 inhibitors, of course, are there now for everybody. And this last slide that you mentioned, it really gives guidance about how to treat these patients. As far as neurohormonal activations are concerned, neurohormonal activator drugs are concerned, it appears that below the ejection fraction of 60% or so, there's incremental benefit as the ejection fraction keeps falling. So definitely for all patients of mildly reduced ejection fraction and for patients of preserved ejection fraction below the EF of 60%.